Welcome back to Labor and Health, the sequel, part 2, day 1. We do have a hard stop this afternoon. For those who are aware, we're going to tour the coroner facility, and we don't want to miss that. We're all excited about that. So with that in mind, the first thing we're going to talk about today, or this afternoon, is a coroner issue. And I believe the first people up are the Board of Coroners. Do we have somebody up for the Board of Coroners? And Department of Health can feel free to come up and jump up the table if you'd like. Or if you don't like, come up anyway. I saw Senator Hutchings. We got Senator Hutchings with us. And Representative Flitner's here. We got a good group this afternoon. So Board of Coroners. How about we start off with you? Franz, you're on time, so you get to start us off this afternoon. Because I'm not seeing anybody from the Board of Coroners. So if they show up late, we'll talk to them. But go ahead and lead us off, Franz.
Good afternoon, Mr. Chairman, Madam Chairman, members of the committee. I was hoping to share a brief presentation on the screen share on the Zoom. So if you give me a moment, should be able to.
While you're getting that together, we will mention that we have a famed legislator in the room, Representative Sweeney. Thank you for joining us. You can stand up and take a bow if you'd like, sir. Oh, you are standing up. Thank you for coming to our committee, Representative Sweeney. Okay, go ahead, sir.
So, Mr. Chairman, members of the committee, again, my name is Franz Fuchs. I'm a policy analyst with the Department of Health. We were asked to give, looks like we got this Zoom error again, a brief presentation on a concept of what we're calling a statewide medical examiner. Mr. Chairman, you and some of the coroners requested that we sort of dig into this topic and sort of analyze it. So we were sort of presenting this as sort of the costs and the benefits of having a statewide medical examiner in Department of Health or whatever agency you designate, similar to what the state of Montana has established in the last couple of years. So we have a lot of slides here. This entire presentation and the methodology behind was developed by our fellow Garrett. Unfortunately, he's out sick today, so he was going to give this presentation, and it was going to be some good experience for him. But in the interest of time, I really just kind of want to skip to a real brief summary of these slides and not really dig into the weeds. When we did this analysis, we really kind of started with the demand, looking at what is the number of autopsies that are conducted every year in the state. And you can kind of see on slide 4 here, it's hovered around between 400 and 500 autopsies per year. And so we project that kind of going forward with a slight upward increase in trend. And just skipping back to slide 3, what is the real problem we're trying to address here? We've been asked to sort of crunch the numbers and sort of develop an option here. But what is the problem we're trying to solve? The problem as we know it, as we understand it, and I'm sure you can get more background from the coroners, is that currently we really have one forensic pathologist who really takes on the majority of autopsies within the state. And he drives around like a maniac from county to county doing all these autopsies. That doesn't accomplish the entire workload, so a lot of counties do contract with out-of-state forensic pathologists. But there is, of course, a wait time, and in some cases, some counties, they may have been locked out. So there may be, these out-of-state forensic pathologists may not be interested in taking the workload from these counties. And similarly, once that forensic pathologist, if he retires, there would be a lot of these counties we put in the same position of trying to find forensic pathologists on their own and going out of state. So really what we're looking at is kind of this impending potential workforce issue of trying to successfully and timely accomplish autopsies for the state of Wyoming, for the counties, for the county coroners. So the potential solution here is that the state would hire one or two medical examiners. In our case, just not to bury the lead, we've gone with our recommendation is 2. And those medical examiners would do autopsies for all counties throughout the state. And then they would charge those counties for those autopsies, and the entire office could likely be funded through self-generated revenue. That's sort of the idea we've explored. The rest of the slide deck kind of goes through, Garrett spent a lot of time building a simulation. So we basically tried to figure out, given that there's uncertainty in how many autopsies happen any given day, they happen in various parts of the state. We got to figure out how many coroners or how many medical examiners would you need to be able to kind of handle that workload effectively without significant delays. And where would you want to put those medical examiners so they could best reach all aspects, all parts of the state? So we have some informational slides from, slide 4 shows the overall trend. Slide 6, for example, shows the number of autopsies requested by county in a year. So you can see, obviously, the counties with higher populations obviously would tend to have more autopsies in any given year. And you can see on slide 7, we have, just more information. You can see 10 out of the 23 contract with out of state. And then we have, Laramie, Fremont, and Sweetwater and Albany being around 40% of the total autopsies in a given calendar year. So the objective really for the analysis, as I kind of mentioned, was to give the state self-sufficiency, really, with this potential impending retirement, with the potential for lockouts from out-of-state medical examiners, what could a statewide medical examiner do? These are kind of the things that might be possible here, right? So there's some significant benefits. However, there obviously is a cost, right? Medical examiners are not cheap. Forensic pathologist is a pretty demanding specialty. So when we look at the cost side of things, you'll see in upcoming slides that generally speaking, hiring 2 forensic pathologists as well as their administrative support structure would cost, I think, about, I'll just cut to the chase here, the slides. We'll kind of cut to the very end here. On slide 16, you'll see the 100 series costs around $1 million a year for the 2 forensic pathologists, the 2 autopsy technicians, and the 1 administrative specialist. That's our estimated cost for this potential option. The simulation slides kind of delve into methodology, but at the end of the day, our conclusion is we're best served with 2 medical examiners placed in Casper. We explored a variety number of medical examiners placed in all different parts of the state, but the travel times and how, basically because Casper is so centrally located, that minimizes the amount of delays and it maximizes the efficiency of that office. So that's where we recommend those medical examiners be placed. At the end of the day, we believe that in addition to mileage, most of that could be offset by revenue. So if we're assuming an average charge of around $1,880 per autopsy for the counties, the state would collect around $900,000 in revenue. So this could largely be self-sufficient by our estimation through revenue generated by the counties. And with that, I know that's a real rush through those slide deck. I just want, in the interest of time, and because Garrett's not here to have the benefit of presenting his work, I just wanted to kind of cut to the chase, give you guys the bottom line. Hopefully that makes sense. The department's obviously we're not pushing pro or con. We're asked to do this analysis and here it is. So happy to stand by any questions, but given that our fellow did most of the work here, I may be limited on some of my answers.
Thank you, Franz. Anybody want to pick on Franz and ask Franz a question? Go ahead, Senator.
Thank you, Mr. Chairman. It's a pretty simple question. You're proposing that we charge the counties for each of these autopsies, and then the state's going to be whole, but the counties won't? I mean, ultimately, where does all the money come from? And how many opportunities are there to do a regular autopsy versus stuff done in criminal activity? Thank you, Mr. Chairman.
Mr. Frugs.
Mr. Chairman, Senator McCune, in my understanding, and I'm sure the coroners could correct me if I'm wrong, is that they are already paying for these autopsies already. They're just paying either private medical examiners or out-of-state medical examiners. So in this case, we'd be collecting the revenue from the counties. We'd be charging them the same way that they're being charged today. So in theory, the county should not be out any more than they are now. It would just be the money would be flowing instead of to other entities, it'd be flowing to a central statewide office. I hope if that answered your question, but I'm sure the coroners could probably provide more detail on their county experience.
Further questions for Franz? Go ahead, Representative Conley.
Thank you, Mr. Chairman. Franz, first I want to pick on, where is Laramie in this simulation? All right, I won't pick on you too much with that one. But I am curious, so it's, the dollar figure you gave is 1,800. Is that the standard that is charged by other states when we, for example, in Laramie need to ship out to Colorado? And so we're paying that 1,800 to wherever, Fort Collins or Denver?
Mr. Chairman, Representative Connolly, my understanding is that that estimated per autopsy cost is 25th percentile of our understanding of the overall costs in the county. So it's actually a relatively, should be a low estimate. I think hopefully that, the coroners could give you maybe more insight on what they're actually paying. But I think it varies significantly by county based on who they're contracting with.
Yeah, Mr. Chairman, then just to follow up, so it's very possible that it could be a savings for counties because of it being at the 25th percentile. I'm also curious about the dollar figure that then is associated with needing to have a forensic pathologist basically show up at a court proceeding, which regrettably sometimes they need to. I would assume that that's additional costs to counties that would be less if we had forensic pathologists in Wyoming rather than elsewhere. Is that a fair assumption?
Mr. Fruks?
Mr. Chairman, Representative Connolly, it may be. I know though, however, that showing up to court was not built into the simulation here. So I can't say for sure that, as far as savings or additional costs, this simulation estimate was built purely based on the workload for autopsies, not additional duties. So that may be an oversight on our part, but something to keep in mind.
I have a feeling this falls under almost the same thing as preventative medicine. We don't know for sure how much we're going to save. But anyway, further questions? Go ahead, Representative or Senator Murphy.
Well, this will probably be a strange question, but do our graduates from the WWAMI program, the docs that we train, could they qualify for these pathology positions, or what additional training would they need to qualify for these positions? Thank you.
Go ahead, Franz.
Mr. Chairman, Senator Furphy, I don't think I would know. I know forensic pathology is a very, very niche specialty in medicine, and there aren't too many of them around. It's to the point where we can't even really get national salary data, from Bureau of Labor Statistics or whatever. So I would imagine there's a lot more training involved than just that would be required past the WWAMI level. If I had to guess, how I don't know for sure. I'm sure there's people in this room that may be able to answer that
Very
better.
well stated. It is a specific specialty which takes a lot of very specific board tests in addition to training. So there's not a lot of them because there's not a huge call for them across the United States. So it is very specialized. Somebody coming out of the WWAMI program would not be prepared without going to that additional training down the road. So potentially they could if that was their interest. I can't see that happening, but you never know. We'd rather they go into primary care, but that's where the need's really at. Further questions for Franz Committee? Oh, Senator Hutchins, I'm sorry I didn't see your hand, ma'am. Go ahead.
Mr. Chairman, I did have a follow-up on Senator Furphy's question, but it was kind of answered. And then you said a few things that, if you don't mind, I'll ask you. You mentioned that the students in the WWAMI program would not have the expertise for the forensic pathology, but you said there wasn't a great need for that. So it's like, whoa, we have a great need here in Wyoming. So maybe that could be something that, and this isn't my idea. This is someone called and spoke to me about this, and it's in line with what Senator Furphy said, possibly getting those graduate students to come here on a rotation type basis to fill in that position as a forensic pathologist, get work experience, and give back to the community. So again, your statement about there isn't a great need for them, but here we are talking about a need for them. Was that just a misspeak or what?
Yeah, thank you for that question. I didn't want to answer questions, Dave, I will. And that is that there is a need for them here, but the training, as far as you mentioned, following someone right now, we don't necessarily have anyone for them to follow. But if they had a sincere interest, and there's a possibility if we went to this model, we could train them and they could go and get that specialized training, the special board requirements that they need, and go probably out of state, frankly, to get those specialized follow-ups or specialized, internships, et cetera. But it's not a misspeak. There is a need, but across the United States, as compared to other medical specialties, it's a very, very small number as opposed to primary care, orthopedic surgery, cardiac, et cetera. But yes, we definitely have a need, but it has to be a student that's absolutely specifically interested in that. And it would depend on where they can get their fellowships and their, their residencies. It's also very dependent on that. So it depends on a lot of things. Go ahead, Chairman Wilson.
Yeah, thank you, Mr. Chairman. So just to flesh out so pathology is a specialty in medicine, just like obstetrics or internal medicine or pediatrics. So a person graduating from medical school would need to put in to do a residency in pathology, which I suppose would be somewhere between 3 and 5 years or something like other residencies. And then I would hypothesize, I don't know about this, that you probably have to do additional work in the forensic side, which is different than just, my experience with pathology is when you're in the operating room and they do a biopsy of your tumor and they send it off to the pathology lab, that's already a physician with a specialty. So obviously the forensic side is has more requirements and more specificity. We certainly do not have a pathology residency program in the state of Wyoming. If a person wanted to be a pathologist, which is, a very different interest. I mean, we're hoping to get people back here who are pediatricians or internal medicine, obstetric people, to go to med school and have a very strong interest in, not to be too fine about it, but chopping up and examining dead bodies under microscopes is a little bit different type of interest than what a lot of people go and do. So, I mean, that's what we're looking for. This is not just some sort of technician job that you get a bachelor's degree and then you do it.
That was a very tactful response. Thank you very much, Madam Chairman. Go ahead, Senator Furphy.
This may be a question for Mr. Boley, but it seems to me there are a lot of hospitals that need pathologists to run their labs, et cetera, to interpret the results. So in my past history serving on hospital board, there was demand for pathologists in the hospitals themselves beyond what we're talking about here. So I don't know if there's still that same demand, but it was in the past.
I will partially answer that if Mr. Boley wants to answer as well, or anyone who wants to answer. And there still is demand for pathologists, but really honestly, and I suspect a large number of our hospitals in the state send out to a lab, outside lab or outside source for their pathology. And there again, just as the chairman was saying, the forensic pathology is much more specialized as a pathologist, but there is a call for it. But right now, I believe most hospitals and, Representative Mr. Boley can either dispute or say you're right, Senator Baldwin, but I believe most of those things are being sent out of state to a reference lab. Dr. Hallinan.
Well, thank you, Mr. Chairman. I would say that there is a possibility of something coming from Senator Furphy's question. Perhaps we could incentivize some of the pathologists around the country, around our state, to get further training, and so they could do the forensic pathology work within their community. I know we have, I would think we probably have about 6 pathologists in the state. I don't think there's a whole lot of them, but maybe we could train them to do their work in their local community. If they wanted to do that, we could incentivize possibly them to do that. Thank you, Mr. Chairman.
I think we should make you part of the solicitation and task force to recruit for these positions. Any further questions for Franz?
Mr. Chairman.
Oh, go ahead.
Thank you, Mr. Chairman. If Mr. Fuchs stated this previously, I apologize for missing it, but a couple of questions. Are the counties requesting this? And secondly, if the program, in your view, would be self-sufficient and be paid by the counties, we're assuming they would use the state pathologists and they would not continue to go to an outside source as they presently do. Is there a fear of, say, for instance, if you're in northern Wyoming, that they would use a pathologist out of Montana. So I guess, flesh out the finances for me a little bit more in that regard. Thank you.
Franz?
Mr. Chairman, Representative Flitner, that's a good question. I think I don't want to dodge the question, but I think the devil's going to be in the details on how well this program is executed, what the customer experience, as it were, if the satisfaction with the counties, with the statewide medical examiner would be. They would obviously be free to contract with other entities. So if the performance of this central agency did not meet expectations, I imagine a lot would probably contract with other medical examiners, and that would damage the financial model behind it. So we haven't fully gamed out all those possibilities. We assume that this central agency would do a good job, that the service level would be, based on 2 in a central location, would be adequate for these counties. But it's certainly within the realm of possibility that there could be some problems in that line. Does that answer your question?
Mr. Chairman?
Follow up, go ahead.
Yes, sir. And Mr. Fuchs, thank you. That does. But, and also, are the counties requesting this, or is this just a German of an idea that comes from your office? Thank you.
Mr. Chairman, Representative Flitner, we were asked to do this analysis by the chairman of this committee, as well as some of the county coroners. I'm not sure if that represents all the counties, but I think it's a significant number of counties would be interested in this idea.
Okay, thank you.
And I believe, Representative, the Board of Coroners came with this request as well when we talked about this, and the registrar, if I'm not mistaken. Further questions, committee? See no further online, seeing none here. Thank you, Franz, for that presentation. You did very well as a substitute. Do we have anybody from the Board of Coroners that's come online?
Mr. Chairman, I spoke with Dave Harness from the Board of Coroners. He referred me to Jim Whips, who's the Natrona County coroner, and he actually has a lot of helpful information about this particular topic, if you'd like to call on him.
Absolutely. Come on up. He's sitting on the back row. It'll take him a minute to get here. Have you noticed committee meetings a lot like church? Everybody sits on the back row and nobody wants to sit on the front row.
So we don't pass the plate.
Yeah, yeah, we're not passing the plate here. Thank you very much for coming down here, Mr. Whips. If you could introduce yourself, then go ahead and tell us, just push that little button there. There you go.
Okay, Mr. Chairman, my name is Jim Whips, and I'm the Natrona County Coroner. I'm also the president of the Wyoming Coroners Association currently, and really this is where this started, was with me and the association in discussion. The crux of the problem is this. We have one forensic pathologist, Dr. Bennett, who is in Sheridan. And not only is he a forensic pathologist, but he's a board certified forensic pathologist. Now, not by statute, but by rule, the promulgated rules, when we do a forensic autopsy, it requires that a board certified forensic pathologist do that autopsy. When we look at surrounding states, really Dr. Bennett is the last one in the region. Northern Colorado just lost their board certified person. Billings, I don't believe, is board certified. Rapid City lost their board certified person. Utah and Idaho have locked us out from doing autopsies. They get too much of their own stuff to do. And we're going to be in a situation, Dr. Bennett is currently running for coroner in Sheridan County, but he's at the age where he's wanting to slow down. He's wanting to, if not retire, slow down and pursue other things. That's going to put us in a real pickle, because it's going to force us, if that happens, to either break statute or rule by going, even if we go out of state, using non-board certified forensic pathologists. Not to mention the fact that when you look at a cost to the taxpayer, having Dr. Bennett here is a godsend. On a lot of our cases, when we go out of state, not only is it costing the county to make that trip, it's also costing the taxpayer as a whole, because we're taking a caravan of law enforcement, DAs sometimes, and other people there as well. Yeah, it just seems that, you know, in the next few years, if you look ahead, we're basically going to become landlocked here, and you're going to find that we're going to have coroners that are either going to break statute or rule or try and call it on their own when they shouldn't, which is going to, in the litigation process, when you're talking about criminal cases and even civil cases, is going to create a scandal and a mess. So I looked at the Montana system that they implemented, and, you know, it's a very good system. It took them a little while to get it up and running and to make it work. But again, it's a system where they set aside in the state a special fund. They divided basically the state up into districts. Those coroners utilize as a resource those forensic pathologists, and they have two of them, I believe one in Helen and one in Billings, both for consultation and for the autopsies. Other states around us do not require that it be a board certified forensic pathologist, and for us it is. You know, and that's based off of standard that we're trying to advance to with international and national standards through the International Association of Coroners and Medical Examiners, the National Association of Medical Examiners. For those offices, especially like myself in Laramie County that are accredited, you know, we have to follow those standards. And I believe that's why the Board of Coroner Standards actually implemented those rules the way they did. So I don't know any questions other than that. I mean, it really comes down to, like I said, being in a pickle with not having anybody to go to. An additional problem that we have is going to fall back to the family, and we see this already for those people that go out of state. If I take an autopsy to northern Colorado, it's going to be, could be 2 months before I'm going to get results back from them, both on the autopsy side of the house and even the lab side of the house, because they force us to use their lab. And so that death certificate, you have a family that isn't able to move forward, whether it's with the state, whether it's with insurance, in any number of things. They're being put on hold for 3 months and maybe even longer for that to happen. When I use Dr. Bennett, and I myself prefer to not go out of state at all ever, you know, I'm getting those results back the very next day. If we have a state medical examiner, I'm assuming it would probably be almost the same deal. These people are working for us, and, you know, not 4 or 5 other states, and don't have such a workload that it's going to take that kind of time frame in order to have results back to us.
Very good. First of all, thank you for your hospitality and letting us come to your facility.
No problem, no problem.
We
I got to
appreciate
tell you, it's not a huge facility, and there's not a heck of a lot to look for, but I can certainly entertain you with a lot of knowledge of what we do and why we do it and how we do it, so.
Thank you. I have a question. I know somebody will ask if I don't ask it, and that would be, when it comes to an autopsy, can you inform the committee what requires a forensic autopsy or forensic pathologist? What determines whether you need an autopsy or don't need an autopsy? I think I know the answer, but the committee will benefit from that.
Basically, from a coroner's perspective, you need to have an autopsy when you can't find the answer yourself. If the medical record isn't indicated of it and you have someone die, or when you have something that, when we call it forensic, and forensic is just a fancy term for investigation, being an investigative piece of any entity. And that's what separates your regular pathologist from your forensic pathologist. We have pathologists and we have coroners that go to, say in the southwest corner of the state, will take medical autopsies into their hospital and do that. Not all the hospitals, the pathologists that we have will do autopsies. They won't do them. Here in Casper, they won't do autopsies if it's just medical. You know, so, but what separates them is that when we have a case, it could be a homicide, it could be certain suicides, accidents, child, infant deaths, overdoses, those kind of things, either criminal or going to end up in litigation, are going to require a forensic pathologist, and in our state, a board-certified forensic pathologist.
Very good. Questions from Mr. Whipps committee? Go ahead, Representative Conley.
Thank you, Mr. Whipps, for being here. I am curious, did you hear the testimony from Mr. Fuchs in the Department of Health regarding the cost that would be associated with having two kind of in-state forensic pathologists, and kind of the assumption that charging the $1,800 would offset that cost? Do you agree with those figures? Do they make sense to you for what you do here in Casper?
I helped put together those figures, so yes, ma'am. You know, and the $1,800 is kind of, I guess, an average. That's what I pay. It's an average. There's counties that will pay far in excess of that for autopsies. And honestly, if we needed to raise that price to the counties, we could probably do that. Now, if you were to go to, let's say, northern Colorado, that price might be a little bit under $1,800. It's getting close to it now. But again, you have to figure the surrounding costs of personnel and time to convoy down there and do this kind of stuff. The bigger cost when you have other jurisdictions, law enforcement and otherwise, that are having to do the same. Wear and tear on vehicles, the additional wear and tear and the life of that vehicle. I mean, the costs beyond just that initial, what you see on paper for the actual autopsies, are far beyond, you know, that $1,800 when we have to go out of state.
Go ahead, Chairman Wilson.
Thank you, Mr. Chairman. Thank you, Mr. Whipps. So sometimes we hear and consider the thought that we require excessive licensing and create obstacles to finding people. It sounds like what you're saying, though, that if we were to, I mean, supposing we took a different route and told the board, well, we want you to change the rule so it's not a board certified forensic pathologist. But the impression I got was that, so then it would fall back on just a person who is a board certified regular pathologist.
No, not even board certified, just a forensic pathologist. You know, there's a difference between a pathologist and a forensic pathologist. There's still extra training that has to go into that. Your regular pathologists, when they do an autopsy, if they're a regular pathologist, are doing a medical autopsy. They're looking at medical causes of death and aren't trained in things such as wounds and all these other things that become part of the investigative process of a lot of these cases. And that's what differentiates that forensic pathologist from a regular pathologist.
So I guess the question, though, would be, would there be any advantage to not requiring a board certified forensic pathologist, but just I mean, it sounds kind of like you're saying that we probably wouldn't be able to find any pathologist who just took an interest in forensics. There probably aren't any of those. Is that what I understand?
Go ahead, sir.
No, there's, you know, they're out there. There's less of them than the board certified ones. And we could certainly, you know, roll back that rule if the Board of Coroner Standards was to do that, or whoever would deal with that. And it would make it a lot easier to get people. But on the other hand, you know, we're kind of taking a step back as well. You know, the reason that rule was put into place was because we were trying to advance with the times and move forward out of the old era of you know, the 1950s kind of stuff that we did, you know, which was pretty hodgepodge and shoot from the hip kind of stuff. So
Follow up, go ahead.
So, and just to be clear, this is not my suggestion. I'm just inquiring. If it were to be rolled back, where would we find the nearest non-board certified forensic pathologists? Are there any in Wyoming?
Go ahead.
not in Wyoming. Now, there is a forensic pathologist in Fremont County. He is basically a semi-retired that contracted specifically with Fremont County. He currently won't do any autopsies under the current coroner, and, you know, we'll resume then, but he doesn't take outside business from the rest of us. So when we're looking at this system of bringing in medical examiners, you know, as an association, we're looking at the benefit to the entire state and not just any individual county.
Thank you. Further questions? Go ahead, Representative Conley.
Thank you, Mr. Chairman. As we go down the road of thinking about kind of loosening up the rule, so I'm just kind of musing out of the top of my head. It would seem to me that with a forensic autopsy, that it is an assumption in part that this could end up in court, whether it be civil or criminal. And I am curious if you have any kind of information, data or anecdotal about the difference in, for example, an autopsy finding holding up in court based on whether the examining physician was board certified or not.
Mr. Whips, go ahead.
You know, I couldn't tell you. I guess it depends on whether this is a medical autopsy that's ending up in civil court, in which case, yeah, it's going to hold up with that pathologist. When you're looking at criminal cases and that kind of stuff, it's got to be a forensic pathologist. You can't just go to your local hospital and have that autopsy done and have it hold up. It won't. You know, and therein lies another concern. You know, if we get to the point where coroners aren't doing those autopsies based off the fact that it's either too inconvenient or they just can't find people to do it, justice in the end is not going to be served in a lot of these cases because it will end up in court and someone's going to get it off because that autopsy was not done. You know, and again, I'm looking futuristic. I mean, we're okay right now, but give ourselves 2 or 3 years and this will become a big issue if we don't get something.
Thank you, sir.
Even just rolling back the rule, you know, would allow us to at least be able to go into other states and utilize their people. Because like I said, it's not a rule or a statute in pretty much most all of our surrounding states.
Thank you. And I have a feeling that in absence of standing anything up from this committee now, that we're going to be a while down the road before we actually have something in place anyway. It's going to take recruitment.
Yeah.
So, and it's just that much more of a delay if we wait. That's my own personal thoughts. Go ahead, Senator McEwen.
Mr. Chair.
Thank you, Mr. Chairman. Just a quick question. Do you know the number of autopsies we're doing that are court-related or criminally court-related? Thank you, Mr. Chairman. In a year.
If you have that figure, go ahead.
Out of probably the 550 that get done, probably about a quarter of those. We're in a situation right now where things keep evolving to where we're ending up in court more and more. And a good example of that is like drug overdoses, where we can now go back against the dealer for homicide when we have illicit drug overdoses. And those, even though it's not required, we always do autopsies on, and they have to be forensic autopsies. I mean, so things keep evolving that involve more and more of that, and potentially more court time and litigation as things move along. So,
And I would add to that, I think there's a public perception, and I would not name names, but I will tell you someone in my household watches a lot of the TV shows that involve a lot of pathology. I want to stay married, so I won't say a name. But there's a public expectation that we dig more into pathology because they solve every crime. They can solve
yeah.
everything on TV.
yeah, it's
In an hour.
CSI. And, yeah.
And some shows in a half hour they can solve it. But I think there's more of a public expectation, so the public is looking more for those things. And that plays into this somewhat.
And so are the courts, to be
Sure.
honest.
For sure.
Mhm.
Senator Hutchins, did I hear your voice, ma'am?
Yes, I've been sitting here with my hand up for quite some time. So I hope I haven't forgotten everything. Mr. Whips, just a quick question or two. When we talk about possibly rolling back the need for the board certified forensic pathologist, do you think that could be done temporarily so we can grow our own pathologist? And then, two, you say we would kind of be going back. I don't think, and maybe you could tell me, we would be going back in time, which would include going back in all the advances we've made in the field. So if we rolled back just the board certified just temporarily, could we still stay up with the times in education, but get somebody here, get them educated, get them experienced, and hopefully help them train new pathologists?
Go ahead, Mr. Whips.
Yes, ma'am. The answer to that is yes, but rolling back that rule, to my knowledge, has got to go through the Board of Coroner Standards. And I personally don't believe that it would affect the quality of what's going on. When I say step back, it's stepping back from current standards, and ongoing progression of standard is what we'd be stepping back from. So I guess, long story short, I don't see that it would probably affect us a lot in the quality of what we got, especially if we had a good forensic pathologist. And, you know, further to that, if we had our own in-state MEs, they could have interns and people working under them that could work to their level. They would be able to supervise and have that kind of program where we could grow our own crop of pathologists as well. So
Go ahead, Chairman Wilson.
Thank you, Mr. Chairman. But so following on that, I think we were sort of thinking that perhaps retracting the board certification rule might make more forensic pathologists available under the current system where the counties find their own forensic pathologists. But is that what you're actually thinking, or are you just thinking that having the medical examiner system whereby we could maybe not require board certification for the state medical examiners, is that what you're looking at? Because I think we're maybe floating the thought that maybe we wouldn't need to have state medical examiners if we just rolled back the rule, and then all the counties could continue with their current procedures of finding out-of-state pathologists. Do you see what I'm saying about?
yeah, I think I understand.
Clarify what
It's going to do a couple things. It's going to make it easier for us, if we lose Dr. Bennett, to go elsewhere without breaking the rules. And it's going to make it easier for us to find some of our own, if that's what we decide to do. Now, here's the caveat to that, okay, as far as us going out of state for everything. In my personal opinion, that's not the right answer, okay? One, because again, you're looking at additional cost to the taxpayer. Two, you're looking at additional burden to the family and the time that it's going to take to try and resolve these cases. But number three, Dr. Bennett does probably well over half of the autopsies in the state. Losing him, if all of us are forced to flood out of state, what's going to happen is what happened to us with Utah and Idaho. They're going to shut us down and say, we can't take all this business, and we're going to be landlocked and not be able to get anybody.
You know, my guts tell me that probably with the expanding populations in at least 3 of the states surrounding us, it's going to become more of a problem, as they have too much of their own business, and we'll have a harder time taking our business, but just my thoughts. Go ahead. Follow
So,
up.
thank you, Mr. Chairman. So it sounds like perhaps what the preference might be, would be to at least temporarily roll back on the rule but still pursue the state medical examiner positions.
Further thoughts, committee?
Mr.
Questions?
Chairman?
Senator Hutchings.
Yes, thank you, Mr. Chairman. Just a quick one. Mr. Whips, you mentioned that when we do go out of state for an autopsy, there's a convoy of police officers, DAs. What is all that about?
When we do a autopsy that primarily is criminal, your law enforcement, and a lot of times, at least in my jurisdiction, the DA will come as part of linking that investigation together. They have to be there when evidence is gathered from the decedent. And basically, it's the coroner and your law enforcement agencies are working hand in hand on these investigations. And your law enforcement agency is working the criminal side of the house and doing that. So they need to be at those autopsies in order to be part of that investigation.
Yeah, chain of custody is part of that issue as well. Further questions, committee? Seeing no further questions, none online. I don't see any hands. Thank you very much for testifying. Thank you again for wanting to see us one more time later this afternoon. Committee, I would just tell you right up front before we go any further, if you look at your emails, we have directions to get to Mr. Whip's facility after our meeting today. And if you don't have a computer, find somebody that does. Okay, time for public comments. Looks like Representative Sweeney is going to talk to us. Thanks for inviting us to your hometown, Representative Sweeney. Go ahead and introduce yourselves for those of us that don't know you.
Pat Sweeney, House District 58. So thanks for being in this great space if you haven't been here before, but and thank the legislature for providing this. So I just wanted to be here in a supporting role. You know, I think it makes sense for a state 1 or 2 medical examiner, whether it's located here. I mean, it makes sense towards the center part of the state if we're going to do this. But I don't see it as a expanding state government. I do see it as a necessity. And down the line further, we're going to, as you've heard from Coroner Whips, what happens if we lose the current situation, and what happens then as a state we're locked out of surrounding states, then what? And so I think if we're proactive now, and as Chairman Wilson pointed out, this is going to take some time to build this. And so not to overload the Department of Health any further than they're already loaded, but I think this is the right opportunity. And I would suggest if it takes a bill or whatever the process would be, that the committee look at that and possibly have it ready for your last meeting. So, and I'm assuming everybody got maps on how to get to the coroner's location out east of town.
If not, we're going to follow you, Representative.
Well, and I was going to ask if you want me there or how you want that handled. So.
Of course we want you there.
So.
We were told.
More fun with you there.
Yeah.
We were told that you were going to show us the autopsy table and demonstrate how it works.
And
Okay, thank you. Any questions for the representative committee? No questions. Thank you again for having
Thank you.
us here. We appreciate it. Further public comment? Online public comments? Seeing none. Public comment is closed. Any comments, committee, directives, moves? Go ahead, Senator Wilson. Representative Wilson.
So, Chairman Baldwin, I'm wondering whether what we might want to do, if the committee feels that this would be appropriate, would be to do two things, actually. One, draft a letter to the Board of Coroners requesting them to review the testimony and amend the rule. And then two, send a letter to maybe the governor's health policy advisor asking the Department of Health to put in a budget request, the next standard budget thing for for two medical examiners, and requesting authority to, gather fees and whatnot as appropriate to make it essentially a self-funded program. I mean, I don't think as a committee ourselves, I don't know that it needs a bill. I think it could be done through the ordinary budget process, but that would be my thought.
Thoughts, committee? What a quiet committee. Go ahead, Representative Conley.
Thank you, Mr. Chairman. And I agree. I'd like to continue the conversation. What I would like to hear from, because I don't see anyone from the County Commissioners Association here, and that's kind of predicated on Representative Flitner's question earlier about the assumption that counties are going to utilize a centralized medical examiner's office. And I'd like to hear from them, honestly, to make sure of that before we go forward.
Thank you. What I suspect is going to happen if we do draft letters as suggested by the chairman is that this will move forward. Likely for those of you still with us for next interim, we may look at some legislation or look at some, formal formation of some sort of an organization, be it the two like Montana, or whatever we come up with. But at least the letters get us started in that direction. If they make a formal budget, then it'll come forward. There'll be public comment period and the county commissioners will be brought into that. But I have a feeling that next interim, at the very latest, we will hear from the county commissioners and we'll bring this up. Matter of fact, I think it needs to come forward for next interim. I will be there. Some people won't. But for those of us, I'm looking down the road to see who's not going to be here. Senator McEwen's sticking with us. What a guy. Go ahead. Director Johann, he snuck in.
Mr. Chairman, if I may, just briefly, again, Stefan Johansson with the Department of Health, listening to Chairman Wilson's suggestion to request that we request authority in our budget for a medical examiner's office. One caution on that for the committee, we wouldn't have the statutory authority to have a medical examiner's office at the statewide level, so we could certainly request the budget. We wouldn't, I think there would need to be a legislative vehicle to give us the authority to operate the office. If that was intended for this supplemental budget, or Chairman Wilson, not to put words in your mouth, if that was intended for the next standard budget, we would have some time in the next interim to do that. Just a brief clarification.
Questions for the director? Oh, no, you just, okay, well, go ahead and comment. Thank you, Director.
Thank you. Mr. Chairman, as far as Fremont goes, I have asked them what the situation is there. We will have a different coroner probably after the election. So whether or not that part-time person will again be available, I do not know. But I can bring that as part of the conversation later on.
And I think that this is a deeper conversation. We need to bring all the coroners, all the county commissioners. It's a bigger conversation, and I think there's a formation of something that needs to happen. It needs to happen. I don't think there's any question about that. Something needs to happen, but we're going to have potentially several new coroners, correct?
Yes.
I mean, we don't know
Yes.
until at least 2
And
weeks.
all I was thinking, and of course I don't know because I haven't, Mr. Chairman, I haven't spoke with them about this at all. But there may be, as the gentleman earlier elicited too, because he's in that loop, whether or not there would be people out there interested or whatever. But I mean, just to keep it going so that we know how to proceed, because I really didn't have any background on this, so it's very interesting. Thank you.
Suggestion, in addition to the 2 letters that we've requested from LSO, suggesting that maybe we carry this as a topic in our October meeting, not for formation of a bill, but just for a review of what's happening and bringing county commissioners and some of the other corners into the conversation, just to keep the ball rolling. What would the committee think about that?
Maybe good prompt LSO to remind us when we put together the agenda.
Yeah, we need reminders, LSO,
Remind us to put that on the agenda.
because the chairman might slip a little bit. Okay, we'll close that topic for now. Now we have just over an hour, which is not all that we'd allotted for the next subject, but we're going to get at least started on this subject and get moving into this. The subject is the healthcare survey process. A hot topic for sure. The first person on the agenda, and I know she's here because I saw her here, Ms. Passano. Carolyn, is she still here? I heard somebody telling her she's up. She's coming, okay.
Advisory for land, I can't imagine that.
We have a crowd, they're ganging up on us.
All women too.
I know, and I'm shaking, you can't see it, I'm behind the table, but I am. Welcome to Labor and Health. You got 2 microphones, spread them out as you will. If you can introduce yourselves and whoever wants to lead off. Oh, we need to get the green light up. We need to get the green light. There you go.
There I go.
Go ahead.
I'm Carolyn Passano. I'm the Executive Director for the Wyoming Healthcare Association, which is a number of nursing homes, about half of the nursing homes in the state. And I have been talking with the members, and we know that one of the things that would be very helpful, not just helpful, it would be excellent for the state of Wyoming and for staff and residents in nursing homes, is having an education program, much like the consultation program that OSHA has. And they get businesses prepared to have OSHA come in and do an audit. And in talking with businesses around the state that have had that service, they say that it was a very excellent thing for them. And from the initial time that the a consultation person came in and looked at everything that would be looked at by OSHA when they came in with their audit, that it helped them continue over time to keep that quality idea as a part of their business. And so because I am not on the ground, so to speak, with running a nursing home, with me today are 2 people who do that and have done that for a number of years. And on my right is Natalie Coral out of Lander. And with, on my left is Kelly Rogie from Douglas. And actually, Kelly right now is not the administrator of the Douglas facility because she is the president of the company that has that facility as a member. And that business is out of Billings, Montana. They also have the hospital that is being built in Saratoga. So I will turn this over to Natalie first, and these two experts will be able to speak more eloquently and cogently about why we need actually education, much like the education that these surveyors would get themselves. Actually, that probably should have been done a good many years ago, because without having that kind of knowledge, all you do is look at paper and look at regulations and say, what does that really mean and how does it look on the ground? And if you had before you that which we had prepared but somehow didn't get here electronically, I would have told you about starting with Plato and Confucius and going on to B.F. Skinner, the psychologist, that it really education. Over the years, we know that person to person does a lot better than just looking at some writing on a page. So with that, Natalie, you just take over.
Welcome, welcome. If you would reintroduce yourself, make sure we all got your name. Go ahead.
Thank you, Senator Baldwin. I am Natalie Coral. I am the administrator at Westward Heights in Lander. It's a 66-bed nursing home. I've been there for 10 years. So I think the point Carolyn's making is that we all want quality. You all want quality for all the residents in nursing homes in Wyoming. The president wants quality. Every president always has. And currently we're a bit in a punitive type of situation, just the way the federal system is set up with annual surveys that take a look at everything. And the comparison to the OSHA safety program is really a great way to look at something that could be educational, steer us in the right direction, and also give us a different resource. Staffing problems aren't new to nursing homes. They're just much worse along healthcare over the last 2.5 years. And so for us to be able to send people out and get the education that we want to increase quality, we're so busy trying to hire great people, get them trained, and hold them and get enough of those people. So what we have coming this fall is more regulations. I think we've all heard about that, and more staffing requirements. And Carolyn has always believed that we would benefit from more education. We believe it too. And some great examples of things that have worked through the pandemic are, we have this collaborative call on Fridays led by the Department of Health, where they bring all the key players together to talk to administrators across the state. And we are kept apprised of many things. And then when new things are coming out, we are given like an overview from the survey perspective on what they know about the new regulatory requirements. However, hearing it and reading it is far different than living it and being surveyed on it. And so I believe that it would be a fantastic idea to maybe run this with civil monetary penalty money, that because those monies in general can be used for things that benefit the residents. And if we're improving quality, that's the outcome we're looking for. And where should this go? I mean, we don't have all the answers, but Mountain Pacific, our quality improvement organization, is amazing in Wyoming, and they serve, I think, an 8-state region. And they are also very active over the last couple of years getting us the right information. But we think that might be a place to look, where we look at having maybe some mock surveys similar to an OSHA consultation, where they come in, kind of take a look, show you some low areas, talk to you about how to get those going, just some outside experts. And I think Wyoming does give amazing care. I think that it would be something that we would want to showcase and compared, all of this is available data. You can look us all up. You can see how we're doing, how well, how poorly in all the measures. And I think it would be easy to show improvement. So that's all that I have to.
Before you give up the mic, for the benefit of the other community members, I know some have lived through this, some have not, some in the audience. Can you just tell us what a survey means? What does that mean? You're having a survey. Just walk us all through it. It's a scary process, I get it, but go ahead and
Right.
just inform
So,
the committee what that means.
in a nursing home, you're surveyed every 9 to 15 months by federal regulation. And they come in with a team, depending on the size of building. And so normally we would have a team to 3 to 5 people in Lander and that show up and they come in and it's just, I've been doing it 13 years of surveys and it still like freaks you out. And they come in, a few of them go look around the building, you meet with the lead surveyor, you have an hour to get a certain number of things to them. And then you have a couple more things that are due, I think, within 4 hours and then stuff within 24 hours. All the while they're out watching your staff. It's not you that should be afraid. It's like your staff are like, people are watching me give care. They're watching me feed meals. They're watching me pass meds. And you know how that is. When somebody's looking at you, you will definitely mess up. And so you do that for 4 days. And I don't think or up to 4 days. And I don't think that it's, our surveyors aren't wanting you to be nervous. They're not wanting those things, but it's inevitable. That's how you feel. And at the end, they meet with you and tell you what they found, deficient practice in different areas. And you take notes, they take it back to a quality control committee. And within 10 working days, you have your statement of deficiencies that you have to fix. If they're serious enough, they'll meet with you during, and that would be called an immediate jeopardy level tag. So it could result in harm to 1 or more people, and they want you to fix it right then and there. So those aren't the great conversations, and you hope you don't have those in the 4 days. But Kelly just finished one in Douglas this week, yesterday. So that's how it goes.
Go ahead,
Thank you.
Kelly, and then we'll ask questions of all 3 of them.
Okay.
Go ahead, Kelly. Reintroduce yourself if you would.
I'm Kelly Rogie. I live in Douglas. I've been the administrator in Douglas since 2009. I have an assisted living in Douglas as well.
I have a feeling you need to move that mic closer, not so much for
Sorry.
us, but for those people that are out
There
in the
we
rest of
go.
the world. Thank you.
I also have an assisted living there. Not to waste a lot of your time to reiterate what Natalie said, but when survey does walk in your building, it is nerve-wracking. And a lot of times you have staff that is new and they don't understand the process and why these people are walking around your building, asking you questions. And staffing's obviously an issue. And now, we have survey come in and they might pull up a seat to watch you give very personal care to a resident who might not be happy to have that care. It's nerve-wracking. So if we could have something come in to show our staff that it's not as bad as it sounds and they understand what the process looks like. We can do all the educating that we want, but to have a different set of eyes. A different set of eyes would also help us see things before we get ourselves in trouble, which goes back to the quality of care for the residents. Different set of eyes, like we were just discussing. You need some work on this care plan. We observed this with a resident. Is this in their care plan? Have you tried this? It sets us up for more of a winning situation versus a punitive, getting ourselves in trouble, like Natalie said, as an IJ. I'll speak a little bit. A survey came into my building at 10:45 Sunday morning, and they exited about 1 yesterday. We had 2 surveyors, both were nurses, both great surveyors. They're up and down your halls, they're asking questions, and remember, no news is good news, but your staff is unnerved. Did I hold the cup right when I put it out for the resident? The new world we live in is, does everyone have their masks on? Did I sanitize right? Did I wash my hands right? Did I accidentally touch the faucet? And sometimes we have 16 to 17-year-old girls and gentlemen working in our building. This is a new experience for them and don't quite understand the stakes that are at hand. It was a great survey. Thank you, Laura. Good surveyors. It went well, but it's a scary situation. So if we could have that come in beforehand, maybe 6 months before we're due, something like that, it would help the situation and ease everyone's stress, as Natalie talked. As an administrator, you have a lot of skin in the game. Your 16-year-olds might not understand that, so the education would be good for it. Do you guys have questions?
Okay, committee questions? Survey them. Go ahead. Go ahead, Representative Bottom.
Thank you, Mr. Chairman. So are you looking at like a video thing like that? I mean, is it something that can be as simple as just having the agenda of what it is that people need to see and then showing that to new hires? And then maybe down the road to remind people if they're noticed not doing things? I mean, what are you looking at? Thank you.
Go ahead.
We have lots of videos. It would be nice to have just a person in the building. Are you familiar with kind of the OSHA walkthrough that the workforce put through? The OSHA kind of comes through and they show you things and they look at it. Somewhat like that. They're digging in your files, they're looking at your charts, they're observing just like a surveyor would, but gives us the things that we need to work on to improve our quality for our residents. Does that make sense?
There are, could I answer that too?
Oh, go ahead, Carolyn.
There are 40 regulations that have to do specifically with quality, and they are scattered throughout. It used to be 178 regulations. It has leapt to 202 since we have had the virus in the state. And when you think about having an education program, it actually has to do with quality. That's what we're looking for in everything that happens in a nursing home. And it impacts like a culture of quality when that is what an education is aimed at. And so with your question, it would be real people helping train through education, real people. And it actually, if you look at it, is making the gossip in one of our Wyoming towns talk about what a good and quality time that their loved one is getting in that facility. They are sure of it.
Chairman Wilson. You
I think I forgot what I was going to say. No, so I'm assuming that there's continuing education requirements for nursing home administrators? And what is the source generally of your education? Is it from like the National Association of Nursing Home Administrators, or, who produces the educational materials that you typically take?
Go ahead, Natalie.
Thank you, Chairman Wilson. We have 25 hours required per year, and it can come from a variety of sources. Through COVID, we had a ton of online education put on by different places like Mountain Pacific and this ECHO program through University of Wyoming and Montana. And then if you can't get enough through those things, then you can go on to the Nursing Home Administrators Board. You can go attend national conferences, that kind of thing. It would be nice if this coincided. I just wanted to add on to your question about how it would be. I think it would be amazing. Like, everybody's at a different level in the survey process, sometimes they show up and you aren't on your game. right? You've got things to fix, and that's why they're coming. But it would be super great if after that survey completed and you got followed through on your plan of correction, if 3 months after that, you could apply to say, could somebody come in and walk through with us and take a look at this? And we can work on it when we're not like under the gun and just keep working on quality improvement processes. I think that's the way I see it. And I think that we're all set up to implement those things like through QAPI programming, but we don't always have the ideas. And Wyoming's, again, remote. Not many of them have big organizations like Kelly. It oversees several, and so she can share great ideas. Well, that's not the situation in all Wyoming nursing homes.
Further questions, committee?
Sorry to do this.
Go ahead.
To kind of follow up with what Natalie was just saying, so when a survey comes in your building, and like she said, you're kind of under the gun and you aren't on your game, what happens when she talks about an IJ, say, you go into a fine mode the minute that they issue that. And you have to write an abatement plan, which is essentially, you're saying your plan, how you were doing your policies and procedures were not working correctly, and you solve that problem before the surveyor walks out and they accept your abatement plan. You are getting fined for every day that you are in that holding pattern of that IJ, which is the CMP funds that we are talking about that we are getting fined for. So if we could not get to the point that we're not on our game, we're not losing money and we're not putting our residents at risk. Does that make sense of kind of the whole process of the survey, how it wraps up? Okay.
Further questions, committee? Seeing none, thank you very much for the
Thank you.
presentation.
Thank you for your time.
Do we have anybody online? I believe we had some presenters that wanted to talk with us. Okay, let's have department come up. You know,
Mr. Chairman.
We're gonna name one of these seats for you. One of our meetings, where you can put your name on a seat.
I thought maybe just a mobile cushion that he
I'll-
could take with him and.
I'll draft that legislation. We'll get it covered for you. Go
Mr.
ahead.
Chairman, we could make a budget request for that if you'd
I'll
like.
embroider that up as my last.
Mr. Chairman, members of the committee, Stefan Johansson with the Department of Health. I'm also joined to my right by Laura Hudspeth, who is the administrator of our Office of Healthcare Licensing and Survey, the topic that we're talking about. Given your deadline to go tour the coroner's office here, we can be brief. We did provide you, starting on slide number 18 in your materials, an overview of the survey process. Mr. Chairman, I'm more than happy to walk through that. If you'd like me to be brief there, I certainly can. And we can talk about the survey process and the topic that was just mentioned with education.
We've been at 30,000 feet all morning. Let's go to 25,000 and go through it.
Mr. Chairman, again, being brief, I don't have to walk you through every slide here, and appreciate my friends at LSO walking through it. Slide 19 really just describes that this Office of Healthcare Licensing and Survey that exists in the Department of Health wears two hats, basically both the state and federal side. On the federal side, as was being discussed by the previous speakers, our folks essentially do work on behalf of the federal government for survey and compliance for CMS, so Medicare and Medicaid certification. That involves a whole host of different types of providers, different types of conditions of participation in those two programs that are surveyed. We can certainly provide additional detail there, answer any questions you have. But it's important to remember that the office that we operate does have those two roles. On the state side, it's really about life safety, so things like construction standards in healthcare facilities. That's really our charge from the state law. That's also a function that Laura and her staff perform for the Department of Health all around the state. On slide 21, Mr. Chairman, you can see just a breakdown of our operations. We have a biennial budget in this office of approximately $5.4 million. Almost 80% of that is federally funded. And we have 24 positions, which you can see the vast majority of those are our healthcare surveyors and our life safety and construction surveyors. We have Laura's position as well as a small administrative staff in that office. I do want to mention, because Laura is probably one of my most senior and experienced employees in the Department of Health who does an excellent job. This is a hard office to staff. In Wyoming, with such long streets between our towns, our surveyors are on the road all the time. It's very challenging work. We often have a lot of vacancies. And I know I'm giving you kind of the other side of anytime we talk about CMS, compliance, enforcement, survey, we're not the most welcome people at the picnic, but it's certainly a job that has to be done, both on the state side with life safety and because it's federally required by law for standards with Medicare and Medicaid funding. But just thought I'd mention that it is a difficult office to staff, and we're lucky to have the staff that we do in that office. Slide number 22 just gives you a kind of a breakdown of some of the things that healthcare surveying does. As was mentioned before, surveys can be scheduled or they can be unannounced. For example, our surveyors go into facilities to investigate complaints that have been made, either by residents or on the part of their families, others, staff, et cetera. And then there's also kind of predetermined things like recertification surveys for different types of facilities that happen more on a scheduled basis. Finally, Mr. Chairman, on slides 23 and 24, you can just see a very high-level breakdown of the number of providers that are surveyed and kind of the type there. And then finally on slide 24, specific to nursing homes, which is more of the topic we're talking about today, just a little bit of breakdown if the committee's interested, some fun facts on the volume and the percentages. But Mr. Chairman, I thought I'd close with addressing some of the items that were discussed by the previous speakers who did a great job, very eloquently describing what I think all of us would agree with and not oppose, which is more education and quality for our facilities. A few clarifications I wanted to offer the committee is that with our Office of Healthcare Licensing and Survey, and I think this is very well understood, our surveyors on the CMS certification side could not act as these educators. There's a conflict of interest there. So the question then becomes, if this was something the state wanted to pursue as an office with state employees, similar to what was mentioned with Workforce Services or OSHA, that would be an office that would need to be separate and distinct from Laura's, just because of that conflict and really prohibition on the CMS side from doing that. Again, that doesn't mean that we oppose the concept at all in the Department of Health. Obviously, as was mentioned, we all struggle with turnover in staff. That includes administrators. That includes some challenges when it comes to survey and knowledge of what's coming. So education is certainly a big component of that. But what the state's role is there and how that would look as an office that the state would provide generates all of the questions we love discussing, which is how much does that cost, how many employees is it, and where does it live? And we're certainly at the table to have those conversations. Secondly, Mr. Chairman, I would mention, as was discussed previously, there have been somewhat of a new area with survey is what we call CMPs, or civil money or civil monetary penalties. Penalties that are assessed on providers, assessed on nursing homes for certain non-compliance measures. As was mentioned, and it's absolutely right, the state does retain those funds. They're put into an account. But I wanted to offer a few clarifications. There's some very specific ways those funds can be used and ways those funds cannot be used. One is for emergency purposes. So we do have a small set aside of civil money penalties that would be for things like facility closures. If you remember back in 2015, 2016, we had some facilities that the Department of Health took into receivership. And I think on the preparedness side, it would have been nice to, if necessary, in an extreme emergency, to have those funds there. So we do reserve some of the civil money penalties for eventualities like that. The rest of that account can be used and facilities can apply for that for very specific types of projects. Funding mock surveys through a quality improvement organization. My understanding, and Laura can correct me if I'm wrong, is that CMPs cannot be used for that. That doesn't mean there isn't a need, but very specific quality improvement projects like staffing issues, or you've been cited or surveyed for pressure ulcers that seem to be an issue, and you want to, as a facility, have some funding to do quality improvement around those very specific issues. Those can certainly be used. And Mr. Chairman, members of the committee, we'd be more than happy to provide a breakdown of what the allowable uses of those funds are. But conceptually, I think what was presented before, again, certainly no disagreement here that however education can be provided to our facilities, whether that's through state resources or through education about the education resources that are out there. Operating 5 direct care facilities ourselves in the Department of Health, we're also subject to survey and often need to retain firms and have technical assistance, quality improvement activities, mock surveys, and we certainly have those needs from time to time ourselves. So kind of a 30,000 mile an hour overview, Mr. Chairman. I'll hand it over to Laura Hudspeth for anything I might have missed or grossly misstated. But again, we're happy to stand for any questions. Laura?
Mr. Chairman, members of the committee, good afternoon. Everything Stefan said is accurate. Again, these funds, the civil monetary penalty funds, are to reinvest in the nursing homes. Nursing homes can apply, outside agencies can apply, associations can apply, and as Director Johansson mentioned, they're really for specific projects for between 1 and 3 years, and they have very specific outcome metrics and monitoring and a plan for sustainability after the project is complete. But, areas that our nursing homes struggle with, like perhaps ways to address staffing or improve pressure ulcer care, reduce polypharmacy, all of those areas could be applied for through a civil money penalty project, initially through the Department of Health, and then CMS does the final approval.
Very good. Questions, committee? Senator Furphy.
Thank you, Mr. Chairman. Let me ask you about the process. So when you go in for a survey and you find these major problems, how quickly do you go back in after you've developed a plan with the home to go back in and survey and make sure they've completed the plan? And then the second part of my question is, what happens if the home wants to appeal the process? They feel they've been picked on by someone unfairly. What is the process for them to follow? Thank you.
Director, go ahead.
Mr. Chairman, Senator Furphy, great question. I'm going to rely on Laura here, but I did want to, two things. Number one, it depends. It depends on the type of survey, but there are processes that Laura can expand on for the types of things you mentioned. And I assume you're referring to on the Medicare, Medicaid, CMS side of the survey process versus kind of the state life safety and construction side. But we can certainly provide information on both. But as Laura will expand on it, it really does depend on the type of provider and the type of deficiency that's cited. But there are standardized processes on all of those to either develop a plan of correction, come into compliance, contest the citation, et cetera. And I'll ask Laura just to maybe walk you through a few examples.
Mr. Chairman, Senator Furphy, for example, if it's an immediate jeopardy situation in a nursing home, which is rare, I mean, it happens, but not often, that means that there's serious threat to health and safety of the residents. As the previous speakers stated, we ask for an immediate action plan that the nursing home implements, and typically we wait for that to be implemented so that we know that some action plans have put into place so that it removes that jeopardy. With the other deficiencies, the nursing home gets what they call a statement of deficiency that outlines the deficient practice, and then they put together a plan of correction and determine the data compliance. And I know they try to get that as soon as possible to come back into compliance. So they do that usually within about 45 days or sooner if they can. And then once that data compliance has passed, my office will either go back on site or we'll do an off-site review to verify that they're back into compliance. Now in terms, thank you for the question regarding if they want to dispute a deficiency. There is an informal dispute resolution process, and my office, we encourage it. We encourage the facilities to utilize it. So if they ever feel healthcare licensing and surveys is an error, I encourage them to write a letter to me, and it's submitted within 10 days after their survey. And they give us additional information on why they feel we may have missed something or interpreted something wrong. So after they do that, we get together within healthcare licensing and surveys a new team of surveyors who are not familiar with this situation. They review the deficiency that was cited. They review the additional information that was provided by the nursing home. And then we ask the nursing home to either meet with us, via Google or in person, and they talk through the additional evidence so that we understand it. And if we have any questions at that time, we ask them for clarification. So we do that, and we do that fairly frequently. And I can tell you within the last 2 or 3 years, about 42% of our citations have been removed because we got additional information to show that the facility was actually in compliance.
Further questions, Representative Ottman?
Thank you, Mr. Chairman. I've been through 3 school recalibrations, so I'm kind of familiar with some procedures. But for some background, one, I was wondering where and how is the civil monetary penalty collected, and from what resources does it come from? And then secondly, if you have yourself, maybe I misunderstood, 5 nursing homes that get, no?
Mr. Chairman, Representative Ottman, sorry to interrupt. The Department of Health oversees 5 direct care facilities. One of those is a nursing home. We are bringing on 2 additional nursing homes at the campus of the Life Resource Center and the Veterans Home in Buffalo. But I was mentioning our 5 direct care facilities: the State Hospital, the Life Resource Center, the Pioneer Home, Retirement Center, and Veterans Home.
Okay.
Those are all subject in some form or fashion, either federal or state, to survey and certification process.
Follow up, Mr.
Go ahead.
Chairman. So if there is items that need to be corrected and you bring in people, to help you before all that, how is yours paid for compared to what a private facility would need to come up with that funding and people?
Mr.
Thank you.
Chairman, Representative Ottman, it's a great question, and obviously as state-owned facilities, we look and act somewhat different, but in many cases, the way we handle that is very similar to what a private facility would have within your budget, within the revenue that you collect. We pay for those types of services when and if we need them and if we can afford them. And I'll give you an example. We are bringing a nursing home, a new nursing home for veterans online in Buffalo this year. And part of that, because the staff up at the Veterans Home have never run a nursing home before, there was a lot of training and a lot of preparation necessary. We used revenue from that facility to hire a third-party vendor to help the staff learn things that are necessary to operate a nursing home, various training requirements, staffing requirements, reporting requirements, and even, as will occur with that contract, conduct a mock survey. So it really comes down, I think, to what facilities have in their operating budget, and some have at times more than others. So we totally understand. I understand at my level, that's not always available. That's not always something a facility can do because we live that as well. But those organizations are out there. Some are better than others that provide those types of services. But it really is dependent on the facility's operating budget and if they're able to make those expenses.
Follow up, go ahead.
Thank you, Mr. Chairman. And then to follow up again, where the civil monetary penalties, what is that? Thank you.
Mr. Chairman, Representative Ottman, the civil money penalties are imposed by CMS based on the survey findings and based on the seriousness of deficiencies. So not all deficiencies get civil monetary penalties, but some of them do. So once that process happens, the nursing home is notified that a civil monetary penalty is imposed. They have an opportunity to write to CMS and say, we're not going to request a hearing, so they'll automatically reduce the civil monetary penalty by 35%. They may also request an informal dispute resolution, which could potentially eliminate the deficiency, and they wouldn't get a civil monetary penalty. But what happens then is CMS imposes the penalty, and the state of Wyoming gets back the Medicaid portion of that penalty. CMS looks at the number of Medicare, Medicaid residents in the facility at the time of the survey, and CMS keeps the Medicare portion, but certainly the larger portion is Medicaid, and it comes back to the Department of Health, and then it's used to reinvest into the nursing homes through these projects, civil monetary projects.
Further questions?
Mr. Chairman?
Go ahead.
Mr. Chairman, thank you. If you could just give the committee an idea of what the dollar amount might be. I'm sure that the penalties vary, but what might a facility be looking at after one of these surveys was completed if they were non-compliant in several areas?
Mr. Chairman, it really varies depending on the deficiency. It can be, I've seen some that are $650. In Wyoming, I think I've seen one that's $170,000. But in general, I can't give you an estimate. But they really vary depending on the seriousness of the deficiency, and CMS also determines, is it a per instant, a CMP, just a flat amount, or are they imposing a civil monetary penalty on a daily basis until the facility's back into compliance?
Director.
And Mr. Chairman, Representative Flintner, if I might add to that, just as an aside, Laura's survey team really doesn't have responsibility for determining those amounts. So they do the survey work, determine if there's a deficiency, what that is. They're somewhat blind to what the penalty that will be imposed is. That comes from a head office, a federal office. And in the past several years, they have implemented a pretty standard approach across all states that determine, they put the survey, the deficiency, the citation into a data system that essentially spits out a number. So it's federally imposed, and I'm not trying to pass the buck here because we are we are an arm of CMS in this office to do this work. But there have been some I think perceptions before, and don't necessarily blame folks for having them, that our surveyors are trying to get as much money as they can from penalties, and that's certainly not the case. They are blind to that system. Something that might have led to that misperception is in the changes that have happened over the recent past with CMS. They really have, in addition to that data system that spits out the penalty, they have a form letter that they use to send to facilities that says, based on the recommendation of the survey agency, here's your penalty. Again, I think Laura can correct me if I'm wrong, our surveyors have never recommended a monetary penalty in our history. So there might be some confusion there that we are recommending the penalty. No, we are citing the deficiency. And CMS's communications could probably be improved there. So just an aside for the committee, but Laura's absolutely right. Those penalties vary. The account right now, correct me if I'm wrong, we have, I believe, $400,000 or so in the emergency fund for, potential facility closures, and about the same amount, maybe a little bit more if I'm not mistaken, that can be used for those quality improvement projects that we mentioned, those very specific projects that facilities can apply for.
Yeah. Yes, 300,000 for the emergency and 400,000 available now for applications.
We would rather never have to go through
Yeah,
the closure issue
just
again.
make sure.
That's sort of in our rearview mirror, and I thought it was almost a disappear. Thank you, Director, for bringing it back up. Further questions, committee? Go ahead. Oh, they're on every side of me. Let's go to Representative Conley first.
Thank you, Mr. Chairman. So if I understand correctly from the request of the nursing homes, is that some of this money be used to establish within the DOH a unit that would have staff that could help them prevent future negative findings in one of these surveys. So my question is, are you familiar with any other state that has an in-house kind of unit like is being suggested by the agencies or by the nursing home companies?
Mr. Chairman, Representative Connolly, I'll let Laura provide her perspective. If there's a state that has a healthcare survey education arm, I'm not familiar with one, but I will answer your other questions. That just to clarify, I think the suggestion, and I've met with Ms. Passano and Natalie, and again, a great suggestion. Additional education is nothing we would disagree with. Just to clarify, civil money penalties, I do not believe would be able to fund an office like this. Those funds that we have set aside from the fees that are assessed on nursing homes would not be able to fund a comprehensive survey education office. However, it's, I think, a policy question for this committee and the legislature. Is there a role of the state in doing more with healthcare facility education when it comes to survey? If so, then certainly that office could live kind of sequestered from Laura's in the Department of Health. It could live elsewhere. There's a lot of options there, but the civil money penalties in particular, I do not believe would be able to be used for this purpose. However, those projects that we're talking about, the facilities can apply for to use are somewhat survey related or tangential to the survey process, because often those projects are aimed at correcting specific issues that would be surveyed and potentially tagged as deficient, if that makes sense.
Follow up, go ahead.
I do have a follow-up, or perhaps a slightly different question, but it might more be for the nursing home. That this morning, when we talked about the upper pay limit, we heard of the hospitals willing to assess themselves or increase their assessment from 0.5% to 1.5% in order to get something that they knew was going to be beneficial for them. I'm curious if the nursing homes have considered something like that as well, to be able to fund this within the Department of Health, for example, because this other money, the civil monetary funds, isn't available. Everyone agrees with that. But is there the possibility to, in some ways, self-fund it and either set it up through the Department of Health or through your own professional organization? I'm just curious if that's a possibility.
Oh, Mr. Bully, I believe, has a comment from the back row. That's the first time I've ever seen Mr. Bully run.
Mr. Chairman, committee members, Representative Connolly, Eric Boley with Leading Age Wyoming. We do have a couple of UPLs in place for long-term care. I think the thing to realize is that those assessments actually help to make up the losses that they're incurring on Medicaid patients. And so we're still losing money every day on our Medicaid patients. And the programs are very different. We do have one that's specifically set up for the governmental nursing homes, the non-state-owned governmental. The private nursing homes don't have a UPL. They could potentially do something if they wanted to, but again, it would more than likely be used to make up the losses they're incurring on their 70% of their patients that are Medicaid patients. So we already do have 2 UPLs in place for long-term care.
Thank you, Mr. Chair. Short answer was no, right?
What's that?
Just said the short answer is no, that they really don't want to be assessed, honestly. So really what the request is for the state to set up a new unit.
Go ahead.
Mr. Chairman, Representative Conley, I'm not sure a UPL could be used to fund this particular program. I think a UPL could be used to increase the amount of money that they have in operations, and then they could potentially find a way to fund it. But I don't think the CMS would allow us to set up a state plan amendment that would allow us to do this particular program with an assessment.
Director has an answer. Go ahead.
Mr.
sir.
Chairman, Representative Connolly, I think Mr. Boley's right that I don't know if the current nursing home UPL program could be used for that purpose. However, what I'm hearing you saying, correct me if I'm wrong, is a similar concept of an association of nursing homes or any provider pooling money to say for facilities that need it, let's share some cost here and provide some education to ourselves. That's something certainly we do in the Department of Health with our facilities. Again, pretty different in how we operate with a state appropriated budget. But we try to pool those resources among our facilities. Mr. Boley, Ms. Passano, other facilities could speak to if that would be a possibility. But I think your understanding is correct in that the concept here would be, either state financing available for education or a state office to provide it.
Thank you. Mr. Chairman.
Thank you, Mr. Chairman. So just some brainstorming thoughts here in 2 different directions. One is the Ombudsman's office. Is that in survey already? I mean, is that in, what program is that in?
Madam Chairman, that's all roads lead back to the Department of Health. That's in my office in the director's office.
But I mean, so not directly under, so I mean, could that, my first thought was, and this is not as to whether the wisdom of funding or the source of funding, but as far as a placement, it seems like that might be, I mean, those are people that already go out to nursing homes and are looking at things, and I mean, maybe that would be a seat. The other thought that comes to mind would be the School of Health Sciences. You have people there who are learning to be healthcare people, and it seems to me that maybe working with the university through health sciences might be able to set up a program along those lines in some way. I mean, they're good at educating people. That's what they're there for. So I'm just brainstorming. That's all. No problem solved at this point from my end, Mr. Chairman.
Productive brainstorming. That's good. Further questions, committee? I don't see any hands online, at the table. Any further comments, or we'll let you off the hook? Go ahead, Director.
Mr. Chairman, just in closing, I would again echo my sentiments from before. I've had discussions with both associations that represent long-term care and nursing homes, and Department of Health is certainly at the table to explore options to improve quality, whatever those avenues might be. And so we hate to be the fly in the ointment here, throwing wet blankets on some of the options of how money can and can't be used. But I think it just better informs policy. But we're certainly supportive of the ability to help our facilities out, especially in this day and age when we do see so much turnover. We deal with it ourselves, and that education gap is most certainly there. I think the question for this committee and all of us working on this is what are the best vehicles to provide that and finance it. So I'm happy to have further conversations with this committee, with the association folks and the facilities on how we can be more helpful on those lines.
Very good. Okay. Mr. Boley has a question. You guys finger on the button there.
Well, Mr. Chairman and committee, I was going to jump in just for a bit of public comment because I haven't commented, but I would just reiterate that this is an important topic. And for those of you that don't know, I do have a nursing home administrator's license. I've held it for 22 years. I've been through 15, I believe, of the surveys before I came to the association. And it's changed over the years, and it's gotten worse. And not because of anything the state's doing, but because the federal government is really cracking down, and they've actually vilified long-term care facilities through this whole process. And it's no fault of the long-term care facilities. It's become more punitive. There's new rules of participation that are rolling out in October, hundreds and hundreds of pages that are much, much more difficult for us to adhere to and be prepared for. So the survey process is a daunting task. And for long-term care facilities, they're surveyed every single year. Hospitals, critical access hospitals, are surveyed every 3 years or 5 years, depending on recertification. And our other facilities, our PPS or our acute care hospitals that are not critical access, they go through joint commission, which helps them keep certification. But this is a different animal. The civil monetary penalties, they're difficult. They really are. When you consider that our facilities right now can't staff to the levels that they need to even fill their beds, and they're at 60% of occupancy where they used to be 85 or 90% occupancy. And it's only because of staff, but then we're being judged because of our staffing levels. And that's part of the survey process. It's part of the 5-star rating process. It's a brand new requirement now that we report turnover of administrators, chief nursing officers, and that's all factored into the 5-star rating of our nursing homes. It's just become a much scarier process for us. And so the education arm of this is really, really important. And I think we're all trying to wrap our heads around what these new rules of participation look like. So I think we're anxious to explore every opportunity that we can, but realize margins are razor thin at best when you consider that in nursing homes is kind of an economies of scale. The more patients you have in, the better off you're going to be. And it just makes sense because you have to staff to a certain level. So you've got high fixed overhead costs. And so if you have more patients to spread that cost over and you have income, even though it's Medicaid most of the time, it still helps the bottom line. But our nursing homes are struggling right now. And so all of this is just scaring all of us tremendously. And we're trying to figure out the right way to navigate this and to make the survey process a learning process that's not so scary and not so punitive. But unfortunately, I feel like CMS and the feds are really putting a lot of downward pressure on us right now. And they're really creating a situation where we're set up to fail, and it makes it more difficult. So with that, I'd answer any questions, but appreciate you taking the time to listen to us today.
Oh, Chairman Wilson.
I only want to offer the nursing home folks, this doesn't help you, but I do actually have some understanding of how this feels, because some years ago, before I came to Wyoming, I was a medical records coordinator and QA person at a nursing home in California. And Medi-Cal, which is their Medicaid people at the time, were extremely slow in paying. It was about 90 days from when you billed them before you got paid. And so we were so short on funds at our nursing home that we were not being able to pay the grocery store bill. So the grocery store cut us off on, being able to buy on account. So we weren't able to buy fresh fruits and vegetables. So we were serving the residents canned vegetables, at which time then the state came out and dinged us for failing to give people fresh fruits and vegetables, which we couldn't do because they themselves were late payers. So I do sympathize. That doesn't help any, I know, but.
Talking about food, this committee does that a lot. We do talk about food a lot.
That's true, it was California.
Yeah.
All
No-
bad things.
no
originate
comments.
there probably, but
Okay, let's move on to
Just
public comment. I believe we've got one online who's been waiting for a while. She disappeared. We were too long-winded for her. Public comment in the room. You may.
And I just wanted to comment to the providers, first, thank you for doing some, really difficult, hard work in the state, and we really appreciate that. That being said, and the good chairwoman and I have our heads together, and I just want to say, regardless of how incredibly sympathetic I am to what you just talked about and presented to us, know that we're in a legislature, honestly, that has very little appetite for what is often called growing government. And what you're asking for is a new unit within the Department of Health in order to do the work that you talked about. And I just don't see that happening. I mean, this could just be me, but I just don't see that happening. However, we would, there's a couple of ideas out there that could be really innovative, honestly, that perhaps we could look at, right? And so I'm just going to encourage you to go outside of the state's going to take care of it by establishing a new unit within DOH, because I really don't think that's going to happen. But maybe something at the university, maybe something with an assessment on the nursing home administration, whatever that can be facilitated by the state. I don't know. What are other states doing along this line? We all don't want you to be fined. We don't want our residents to have that substandard service, right? Right, all of that, right? We all want the best. But thinking that we're going to get a new unit in the Department of Health, I think is probably not the best direction to go in. Just my 2 cents.
Thank you for those very appropriate comments. And I think that sometimes go unstated at this committee. The bottom line is we're out here for the welfare of the citizens. And it's everybody from the oldest. I had a 101-year-old lady in my office the other day, the oldest patient I've ever taken care of. And I have, 1 week-year-olds, and we're here for the benefit of all those people, no matter where they reside, a home or a nursing home or mental health facility, wherever they're at. And that's our bottom goal, and that's our job. And I think that's important. I think Representative Conley addressed that very well. So we want to work with you. Any ideas or thoughts, committee, you want to pass forward? Chairman Wilson wants to.
Well, just as far as building the October agenda, I think it's in health sciences. I'm not actually sure which program it's in, but the UW does have some sort of Office of Aging and whatnot. Sorry, apologies to them if they're listening that I forgot the name of your glorious unit. But maybe we could invite them to tell us what kind of programming they offer and see whether something apropos might, that doesn't come without a source of funds either, but or anyway, maybe we could ask. It would be good for us to know what that unit does anyway.
And I'm thinking the community colleges may well be included on that. They have healthcare.
Well, LCCC just started the healthcare administration programming, so
Central and Western Wyoming.
maybe we could get a report on some of those, the aging focus from the university and community college programming, and just see. We will be informed and we might find out something helpful.
Another reminder for the October meeting.
Mr. Chairman?
I believe that was Representative Flitner.
Mr. Chairman, thank you. I had a question. OSHA was used as a reference for coming in and providing training to facilities after a particular type survey. And I was just curious where their funding came from.
Chairman Wilson has the answer because I don't.
Well, I'm not sure if I do, but my earlier times on the Labor Committee, I think that state OSHA's funding maybe comes from workers' comp premiums and assessments on the employers. Someone in the back row might, I see no nods.
That sounds vaguely familiar.
I think that's correct.
Okay, thank you.
Yeah.
Okay. For the questions, comments committee. Seeing none, public comment is closed. Thursday in Labor and Health is closed. My phone tells me that we're 13 minutes away from the coroner's office. That is for legislators only. So please come, please. Okay, thank you very much. We'll see you bright and early in the morning.